Good day, everyone, and welcome to the Mediterranean Emergency Medicine Congress at Semmelweis University, Budapest, between the 14th and 17th of August, 2025. Our next speaker, Dr. Csaba Dioszeghy, will address a topic common in everyday practice that rarely gets the attention it deserves.
Good morning, everyone. I have no financial conflict of interest with regards to this topic or the presentation to declare, but I am the principal investigator of a multi-center research study we are preparing to launch studying the topic I will describe in this presentation. Today, I would like to address a topic that is a daily reality in our emergency departments, yet it continues to be one of our most profound challenges: the unsolved mysteries of medically unexplained symptoms.
We'd like to ask you all to think back to your last shift. I am sure you had at least one patient who arrived with specific, perhaps slightly alarming symptoms, but the test results you have received back after careful examination were all negative or not really aligned with what you have expected. Were you surprised when you reviewed these results? Or perhaps you already had this hint during the history taking or physical examinations. It's likely that the more experience you have, the less surprised you were. However, you might have continued to pursue a diagnosis by referring the patient for further diagnostic tests, as you really didn't want to miss anything. Let's do another test just in case. Or you might have tried to explain the symptoms with a reassuring and plausible explanation, such as a viral infection, post-viral, or gastritis, or musculoskeletal condition. This reassurance might have been more for yourself than for the patient. Alternatively, you might have reassured the patient that you did not find any problems. Their symptoms were probably real, but not explained by any medical cause.
This scenario brings us to the core of our discussion: medically unexplained symptoms, or MUS. There is no universally agreed upon set of diagnostic criteria for MUS, and definitions can vary between specialties and healthcare systems. However, the common definition describes these as physical symptoms for which no sufficient organic pathology can be found to explain their nature or severity. These symptoms can be singular or multiple and are typically persistent, lasting for several months. A key feature is that they cause significant distress or tangible impairment in the patient's social, occupational, or other important areas of functioning. The modern diagnostic systems are moving toward new terminology. The DSM-5 now uses the term somatic symptom disorder, while the ICD-11 refers to it as bodily distress disorder. It is important to note that MUS is considered an analytical concept rather than a formal diagnosis. Some specific syndromes, example fibromyalgia, irritable bowel syndrome, chronic fatigue syndrome, are often included under the MUS umbrella.
So, just how common is this in our emergency departments? The prevalence data is striking. Studies show that between 13% and 18.5% of all ED visits can be attributed to MUS. This figure escalates dramatically when we look at patients who frequently reattend our departments, with some studies indicating that up to 72% of these individuals have MUS. When we examine specific common presentations, the numbers are equally compelling. For patients presenting with chest pain, almost half, 46%, will have no definitive organic cause identified. Similarly, for abdominal pain, this accounts for about 1/3 of adult cases and nearly half of all cases in children. The range of symptoms that fall under the MUS umbrella are the bread and butter of emergency medicine: chest pain, palpitations, abdominal pain, back pain, fatigue, dizziness, headaches, and even presentations that mimic seizures or syncope. Through extensive research, including international multi-center studies, we have been able to identify several common characteristics among patients with MUS. These patients are often younger and are more frequently female. They are more likely to have self-referred to the ED and are, in general, more frequent users of healthcare services. A very significant finding is the high rate of comorbid psychiatric conditions, particularly anxiety and depression. Some studies have also pointed to an association with a lower level of education and socioeconomic status.
The clinical challenge is significant, but so is the economic impact. In the UK, the cost was estimated at up to £12.7 billion annually over a decade ago. Across the EU, the yearly cost is estimated at €74 billion, and in the US, it is a staggering $256 billion per year. These figures clearly demonstrate the immense scale of this issue. However, the financial cost is just one dimension of the burden. For the patient, MUS leads to a profoundly reduced quality of life, which can spiral into social and professional decline. For our healthcare system, it results in immense resource utilization through repeated diagnostic testing and treatments. For society, the impact is felt through reduced productivity, high rates of work absenteeism, and increased disability claims. It is important that we also turn a critical eye to our own perspectives as clinicians. This word cloud contains terms that have been, and sometimes still are, used to describe these patients: malingerer, attention seeker, time waster, hypochondriac. The cartoon of the frustrated physician captures a feeling that many of us may have experienced. This stigma is a significant barrier to compassionate and effective care, and it is a prejudice we must actively work to dismantle in ourselves and our departments. A paper published in the BMJ in 2015 by Yon and colleagues clearly identified that senior clinicians who serve as role models for resident staff are a significant barrier to dismantling this stigma and promoting more compassionate and effective care for this group of patients. I was no different at all, and so I personally took this feedback to heart and actively changed my attitude. Crucially, we must understand that these symptoms are not imaginary. They are real, with increasingly understood biological underpinnings. We are now seeing clear evidence of neurobiological changes, including neuroinflammation and dysfunction of the autonomic nervous system. A key concept is central sensitization, a phenomenon where the central nervous system becomes persistently hyperreactive. From a psychological perspective, somatosensory amplification, the tendency to focus on and intensify normal bodily sensations, plays a significant role. There is a complex bidirectional interaction between the mind and body, mediated by immune-brain pathways, and an interactive model of neural, immune, endocrine, and psychological processes. This table, adapted from the Canadian Journal of Emergency Medicine, offers a useful model for understanding how emotional distress can manifest physically. It shows how anxiety can translate into striated muscle tension, leading to headaches and chest pain, or into smooth muscle spasms, causing symptoms of irritable bowel syndrome. It also demonstrates how cognitive perceptual fields can be disrupted, causing dizziness or confusion, and how in conversion patterns there can be a loss of voluntary muscle function. This provides a clear framework for the mind-body connection in these presentations. This brings me to the single most important message of this presentation. The symptom is real, the suffering is real, the pain is real. Our surprise as clinicians trained in a strictly biomedical model is understandable, but we must evolve our understanding. The patient's experience is valid, even when our traditional diagnostic tools fail to provide a simple, linear explanation. What is the practical approach in the ED? The first and most critical step is always to exclude any life-threatening emergencies. We are good in that. Following that, we must adopt a comprehensive biopsychosocial approach. Unfortunately, we are not particularly good in that, but we can learn. This involves a detailed history, paying close attention to previous attendances, and a complete physical examination. To aid our clinical judgment, several screening tools have been developed and validated to help identify patients with somatic symptom patterns. Tools like the PHQ-15, SSS-8, and SSD-12
are often self-administered, making them feasible in a busy ED, and they have demonstrated good sensitivity and specificity. These tests, which the patients can fill out relatively quickly even while waiting in the waiting room, would provide a validated score about their tendency to somatization. While these can support a holistic assessment, we must be cautious of their limitations and potential for diagnostic bias. A high score for somatization does not exclude a serious medical event like a heart attack. We are launching a collaborative research project between Semmelweis University and the Surrey and Sussex NHS Trust to determine the safest and most effective way to use these tools and hopefully solve the mysteries of medically unexplained symptoms. Our overall strategy in the ED needs to be thoughtful and structured. Once life threats are ruled out, a biopsychosocial assessment allows us to assess both organic and functional elements of the presentation. Of course, the next big question is how to manage these symptoms in the ED. We surely won't be able to fix those, but at least we can avoid further harm by over-medicalising, pursuing wrong diagnosis, or simply kicking the can down the road by reassuring the patient that their symptoms are not significant, so they will go and seek other healthcare professionals with the likely worsening symptoms until someone comes up with something. The crucial step is communication. It is vital to validate the patient's experience. Simple phrases can be powerful. Then we can gently work to reattribute the symptoms, explaining the connection between stress and physical sensations. What we can do in ED, however, is more than just avoiding the harm. We can assist the patients to get to the right track. For many, a simple explanation and the connection of their stress to their symptoms would help enough to find the way out. More complex cases would need more complex treatment and follow-up. According to the literature, a stepped care approach is most effective, beginning with education on lifestyle, diet, and mindfulness. This can be escalated to include psychotherapy, such as cognitive behavioral therapy or intensive short-term dynamic psychotherapy, and in some cases, antidepressant medication. Finally, establishing a clear follow-up plan, such as scheduled brief appointments with a GP, is essential to provide continuity of care and break the cycle of crisis-driven ED visits.
Of course, implementing this is not easy. There are significant challenges. Many of us lack specific training in psychosomatic medicine. Our system is often geared towards over-medicalisation, and we lack standardized diagnostic tools and protocols for MUS in the ED. The stigma we discussed earlier is a major barrier, as is the influence of negative role models during our own training. And we cannot ignore our own medico-legal anxiety, the fear of missing something, which often drives defensive medicine and excessive testing, and the reluctance of admitting that we could not identify any organic cause.
In conclusion, medically unexplained symptoms are not a mystery to be solved with more tests or more powerful imaging. They are a complex and deeply human experience that demands a shift in our clinical perspective. They represent a significant and prevalent component of our work in emergency medicine. They contribute to a massive burden on our patients' lives and our healthcare resources. Our efforts are currently hampered by a lack of uniform diagnostic criteria, a lack of consistent and integrated care pathways, and deficits in our own training. And overarching all of this is the persistent problem of stigma of mental health-related clinical presentations. The mystery of MUS is not in the absence of an explanation, but in our willingness to look for it in the right place, at the complex and fascinating intersection of the mind and body. By fostering a greater understanding of these complex conditions and by adopting a more structured, compassionate, and integrated biopsychosocial approach, we can begin to solve these mysteries, saving billions of pounds or euros and dollars, reallocating resources to areas currently underfunded, and most importantly, provide far better care for this vulnerable and deserving patient population. Thank you.